the biggest fact that causes me the most concern is that these guidelines have no best before, no expiry date. All credible guidelines to meet the Guideline Assessment Committee criteria for an effective guideline, they have to have a period of time over which they function and after which the committee revisits the guidelines to see what were the intended as well as the unintended consequences. Now, the other area that is particularly contentious in the current CDC guidelines is this notion that there's a line in the sand, that if you're below it, you might be okay, and if you're above it, in some states, for example, Maine, you are not allowed to be above it. So in that sense, it's not even a guideline, it's a de facto standard. And the problem with that is there are almost always exceptions to the rules. So that can be irritating to some clinicians, but from my perspective, the value in that line is it causes people to think. And I believe that one of the really difficult parts of our practice over the past few years has been this notion that as long as you give more of the opioid, you will eventually get to a therapeutically accurate and correct dose. And we know that's not true. We know that when you get above 100 morphine milligram equivalents per day, risk dramatically increases. But not only does risk increase, probability of achieving therapeutic success decreases. In the parlance of Vegas, you're throwing good money after bad. And I think by asking clinicians to look at that, in that perspective, while not punishing them, and this is where I think Howard and I would agree the role of education is so important. So I think we have to look at the guidelines as an opportunity, and I think it's an opportunity we can share with our patients. And it's an opportunity that expects every clinician to look at the status quo, for example, the inherited pain patient, and say, is this really the best that it can be? And surprisingly, for some patients, being on a lower dose or not being on opioids at all is dramatically will dramatically improve their pain relief and their quality of life. And yet it's about as counterintuitive as you can possibly imagine if you're on high doses of opioids.
The other area of the CDC guidelines that I think are not clear, they say urine drug tests. They don't say what type of urine drug test. Should it be a presumptive urine drug test done by immunoassay or the more expensive chromographic test called definitive testing? When should you do it? How frequently should you do it? Who pays for it? These are all questions that haven't been answered by the CDC guideline, but they expect the private practitioner to know this answer and act appropriately.
People have asked, what do we mean by the medical Stasi? And of course, historically, the Stasi was a police state organization in the Eastern Bloc that was charged essentially with gathering information on its citizens in order to determine if there was subversive action on their part. Well, in that regard, we wondered and dared to wonder out loud if there was more to the generation of this information through urine drug tests, through risk evaluation mitigation strategies, none of which, by the way, have been proven to be effective for the purposes intended. They certainly cause cost, and some of those costs are significant in terms of patients being discharged from practice.
Think about pain management and the medical community. If we say that really the beginning of oral pain management began in the late 80s, early 90s, we still do not have papers that say chronic pain management with certain controlled substance, such as opioids, are efficacious for the long run. We still do not have papers that's with p-values that treatment agreements help diversion or decrease aberrant behavior. We still don't have papers that urine drug testing decreases aberrant behavior and diversion of medications. We have all these holes that we don't have studied, and in these holes, nature abhors a vacuum. There's no question that nature abhors a vacuum. And who's going to come into that vacuum? The government with regulations. And who makes those regulations? Non-MDs.
Well, from my perspective, one of the challenges in pain management has been to generalize the skill sets that are necessary to effectively manage pain into the more broad base of chronic care. Primary care doctors deal with pain of all sorts and all fashions during their career. But the word chronic pain tends to take on almost a life of its own. I had an Irish fellow a number of years ago who used to refer to the pain patient as the heart sink patient. The one that, and I didn't know what she meant until I realized she meant the one that puts your heart in your boots and you just hold your hands to your head and realize that all ye who enter in abandon hope, because it's going to be a rough clinic. But the reality is we can make dramatic improvements in pain patients' lives. And we can do that not because of opioids or because of interventions, but because we recognize that this is part of a clinical continuum of care. And I think the skill sets that are necessary to be a good primary care doctor or a good specialist are skill sets that have portability and have generalizability, both to the treatment and care of pain patients, but also into the management of patients who suffer from a variety of reasons.